Hi everyone, thank you very much for being here today. I started with a short story. A little over 1 year ago, um, I suffered a knee injury while hiking a 14-mile loop on the Appalachian Trail in Tennessee. So I thought, I don't need to go to the doctor. I'll just wait for it to relieve by itself. But then, like with exercise, I would still suffer from knee pain, and especially sometimes while I'm sleeping. So before this Thanksgiving, I took an appointment with a clinic, and I specifically asked for a female physician to take a look at my knee. So, but when I went, and I was able to make that appointment. But when I went to the clinic, I was surprised that the physician had a male resident who was working with her. So if we think back, why did I wait for 1 year? Well, I've had previous encounters within the healthcare system where my religious needs were not met. So I thought this is not as serious as that. So let's just wait for it. Maybe it will relieve itself. But that was not the case. And another time, also my religious needs were not met. Although they provided really great care for me, but there's some point that was not met. So I'm talking about this as a privileged person who can communicate in English, and this is just an acute illness that happened. But what about other Muslim patients who are not able maybe to communicate in English, or who have chronic conditions like diabetes? So today I am Asma Ali. I'll be talking about medication use and self-management behavior in Muslim patients diagnosed with type 2 diabetes mellitus. This is a study that was done in Britain in 2009, and just the title of the study says it all. Fasting and prayer do not concern the doctors. They don't even know what it is. So this is mainly about communication between physician and patients. And if we look at the first comment from one of the patients who had a chronic illness, so he was recommended to eat yogurt and drink milk, but he felt that he was having flatulence out of consuming these products. So he just disregarded that because he needs to be in a purified ablution state for prayers. So to give you some introduction, the Muslim population is growing, and in 2017 there was 2.15 million Muslim adults in the US. They come from diverse racial ethnic backgrounds, which are mainly minorities. Around 41% come from the Middle East area, 28% are Asian, 20% are Black, and 8% are Hispanic. 58% of Muslims in the US are immigrants. And as you know, we do face some healthcare disparities. Diabetes is an issue within the Muslim community. There are over 150 million Muslims who are diagnosed with diabetes worldwide. And the studies about diabetes in Muslim patients are mainly focused on patient-provider communication and medication modification during the month of Ramadan, which is a month in which Muslims fast from sunrise to sunset. No eating, no drinking. But the month of Ramadan is not just about abstaining from food and drink. It's about behavioral changes, where we're very much encouraged to improve our behaviors and just get rid of bad behaviors. So the idea here is, why not still help these patients improve their behaviors during the month of Ramadan and continue to carry it for the rest of the year where they're still diabetic patients. Just to give you a brief background, what I'm talking about today is a qualitative study that will be part of a bigger project where we are partnering with the Muslim Community and Health Center, which is a primary care clinic that's located in Milwaukee area. The location of this clinic is right next to the headquarters of Hayat Pharmacy, which consists of about 21 pharmacies in Milwaukee area. We're also conducting stakeholder advisory group meetings. We're including Muslim patients who have type 2 diabetes clinicians from the Muslim community and health center, pharmacists from pharmacy, and case managers who work with refugees. The objective that we're discussing today is exploring patients' experiences and their factors that are related to diabetes self-management and medication use in Muslim patients who are diagnosed with type 2 diabetes. The theoretical framework that we're using is the social cognitive theory, which explains that an individual's health behavior is influenced by a triad of factors, and this happens through a reciprocal interaction between these factors. So if we look at this, these are the factors and the determinant of health. If we look, for example, is this the point? Okay, so if we look at the behavioral factors, for example, the patient needs behavioral skills. So they need knowledge and skills in order for them to act upon a behavior. So do they have the knowledge and the skills to identify hypoglycemia? But that's not enough by itself, because they need cognitive factors where they need self-efficacy. How confident are they that they can act about it? Also, we're going to look at the environmental factors. For example, social support or any other barriers and facilitators. These barriers and facilitators could be anything related to their religion, related to social factors, or just maybe physical factors. Sorry. So this table just provides the definitions of what I just mentioned. And this here, like, we can look at some sample interview questions that we included in our interview protocol, but this will be refined more. So, for example, if we look at the first questions, have you experienced any very low blood sugar? When did it happen? What triggered it? And in respect to any social or cultural activities. Also, we'll be asking them in order to learn more about their, if they gained any skills from that. What might you do to lessen it next time? Have they learned something from their experience? Also, when asking about their barriers, what day-to-day things make it harder for you to manage your diabetes? Also, we'll be asking about any connections that they may have made between Islam and their management of diabetes. So we'll be conducting semi-structured one-on-one interviews with 30 Muslim participants who are adults. We're focusing on both male and female participants who are diagnosed with type 2 diabetes and use medications for diabetes treatment. In order to capture the diversity in this patient population, we're using maximum variation sampling. We're trying to recruit 5 participants who speak a unique language of Arabic, and those would be patients who are coming from the Middle East. Rohingya, those are patients who are coming from Southeast Asia. Dari or Pashto, African refugees, English speakers, Somali or Swahili as patients coming from Africa, Urdu, and these are patients who are coming from South Asia. So we will be conducting the interviews virtually or in person, and that depends on the patient's preferences. Also, we expect to have about 30 to 40 minutes long interviews. I speak both Arabic and English, so I can conduct the interviews in these 2 languages, but we will include interpreters for patients who speak other languages. We've developed an interview protocol that was reviewed by Dr. Chuning. We're also be reviewing this protocol with the Community Advisory Board for final selection and revision. Also, we are conducting 2 pilot cognitive interviews just to ensure that the questions are clear and it elicits the intended information. The interviews will be audio recorded and it will be professionally transcribed for data analysis. So 2 trained researchers will use in vivo software to analyze the data. We will use the directed approach to content analysis. And that's because it will enable us to use the deductive approach that's guided by the social cognitive theory, but also we'll be able to expand beyond that to include any other factors that we might have missed by the socio-cognitive theory. This provides our timeline. So we will not start we'll start recruiting during the month of Ramadan, which this year is going to be in April. But we will not start conducting the interviews until after the month of Ramadan. It would be very hard, like to do any interviews during this month. We are planning to disseminate the results in the into conferences and also into journals, which are the Research in Social and Administrative Pharmacy and Primary Care Diabetes. For our future research, we plan to develop an instrument to measure factors that are related to diabetes self-management in this patient population. This instrument can be used by clinicians to help them identify barriers for patients with diabetes, Muslim patients with diabetes. I would suggest maybe it could be used also during the wait time at the clinic, just before seeing the clinician. Also, we're hoping that afterwards we can design a behavioral and educational intervention to help patients improve their medication use and diabetes management, and so that afterwards we can conduct a clinical trial in order to assess the effectiveness of this intervention. Thank you very much to my mentors, to everyone who helped me here, and especially Dr. Betty Chuning. And thank you. Any suggestions or collaborations? I think this is my email.
Thank you very much. You ended 20 seconds early. So we have 8 minutes and 40 seconds for question and answer.
Asma, I had a question for you. So I noticed as you're thinking about your interviews, you focused on the patient's background, but you didn't focus on the diabetes at all. So in terms of whether they're controlled, not controlled, whether they're on injectables or whether they're on orals, I was just, it strikes me as their experience may be different, especially with patients I've worked with. The injectables are a big issue. I don't know whether that is.
Yeah. So we're not just focusing on oral medications. We're also focusing on those who take injectables like insulin. So we're including patients like that also.
I'm not talking about just including. As you think about your purposeful sampling, you should be thinking about getting groups from all of these. So
yeah.
So again, thinking about, since this is really focused on the diabetes, not overall healthcare, including diabetes factors in that as well as you think about who to include.
Okay, yeah. And I think that also will be more refined during our advisory stakeholder group meetings. So maybe we can talk with the clinicians, pharmacists, and even like patients from the community, like to understand like where the issue is really.
So my training was in anthropology, and I'm so glad that medical science is catching up to, listen to the people first, get into the communities before you plan your studies. And so you've only been here a few months, you've been able to make connections in the Milwaukee community and have a plan for research, which is the way to start rather than to go there with a plan of how you want to change things. But I still I'd like to ask you to think what possible avenues could this lead to in research that would provide information that would impact, can you think of a couple of pathways towards impacting healthcare that would be beneficial?
Yeah, actually, even like just, we've only had a couple meetings with the director of operation. Like I had their names, like in the acknowledgement. Dr. Arman Tahir, who's the director of operation from the Muslim Community and Health Center, and Demi Sokels, she's from Hayat Pharmacy, and we've already learning a lot, like from the healthcare model that they have in the clinic and in the pharmacy. There's a lot to learn and to disseminate to other healthcare clinics in the U.S. So yeah, that's a great point. Thank you.
Asma, thanks for this presentation. This is an interesting topic, and I really appreciate it. You broke things down. When thinking about your cognitive interviews for testing your interview program, are you going to be doing that primarily in one language? Is there going to be any sort of sampling of how you choose those pilot participants for the graduate?
Yeah, this is a great question. So initially we were thinking in English doing that, but we may need to do that also in other languages because that's like one of the limitations when using interpreters. We want to make sure that the interpreter is relaying the real message, not paraphrasing what the patient is saying, because that's what we are there for. We're for the patient's experience. So we're also thinking about that. So thank you.
Asma, that was very interesting. Thank you. When you talk about your 30 subjects that you're hoping to recruit for the study, you're also looking at multiple groups, including those that are speaking Swahili and Urdu and such. Is that slicing it too thin? Would you be better off looking at larger cohorts represented in the Milwaukee area that will not force you to be looking at such low numbers of individuals? I can't imagine that you're going to have that many individuals speaking Swahili in Milwaukee compared to the Arabic and the English speakers. Perhaps I'm wrong.
So we came to a conclusion about these languages that we're including and this patient representation with our communication with the Director of Operations from Muslim Community and Hayat Center and Health Center. So he recommended that we include these languages as representation of these patients according to what they see in the clinic. So yeah. Thank you. Yeah. Elizabeth, Dr. Cox, do you have a question?
I did have a question, but KJ already asked.
Okay.
I'll chip in one more thing. I think back to what David had said earlier, with maximal variance sampling for this, age is going to be another concern here. There's just such difference in management and also in day-to-day activities probably. And so from our own work with adults with type 1, even being, in the working typical age versus no longer working made a considerable difference in the types of factors that influence people's self-management. I think I might encourage you to think about focusing the age there, whether you're interested in older adults or you're interested in working age people or you're interested in the very young with type 2 diabetes. Maybe worth just thinking about collapsing that a little bit. There's a lot to represent here, as Paul was getting at, and I think qualitative work does that really well, but you also do run the risk of slicing that too thin. And I think your language stuff is spot on. I'm excited about what this may
Okay. Thank you.
Yep.